and today we will be discussing pharmacology, and we will dive deeper into nutrition implications of polypharmacy in older individuals. Today we will discuss my research question, a brief overview of terms related to the study of pharmacology, a summary of practice guidelines from the text, key considerations for medical nutrition therapy and the nutrition care process, a summary of findings from the literature review, and an application to practice for the RD or the RD-to-be. My research question is, what is the evidence to support the role of the dietitian as a member of the interdisciplinary team in pharmacotherapy and their role specifically when working with seniors at risk of polypharmacy? Data from the CDC suggests that 48.6% of Americans used at least one prescription drug in the past 30 days, and 12.8% of Americans were using 5 or more prescription drugs in the past 30 days. Below are definitions that will aid in understanding the remainder of this presentation. A medical drug is a chemical used in the diagnosis, prevention, treatment of symptoms, or cure of diseases. There are prescription drugs which require a doctor's recommendation, or over-the-counter drugs which consumers may use in their own discretion. Pharmacology is the study of drugs, their properties, and their effects on the body. Pharmacokinetics is the study of drug absorption, distribution, metabolism, and excretion. Polypharmacy is a term that is defined as use of excessive drugs at one time or concurrent use of many drugs, which increases risk of interactions. There are many accepted definitions. Some claim more than 5 drugs, and some claim 6 or more drugs at one time. Older individuals are at higher risk for polypharmacy because there is an increased risk for chronic disease with age. Diseases such as hypertension, cardiovascular disease, type 2 diabetes, depression, osteoporosis, and others that affect more than 80% of people over 85 years old likely increase drug consumption and increase risk for polypharmacy-related complications. Here is a summary of practice guidelines. Interactions can occur between food and drugs that can diminish, enhance, or alter effect of either the nutrient or the drug in the body. Therefore, a basic understanding of pharmacologic principles is important for RDNs and RDNs-to-be. Coordination of nutrition therapy with pharmacotherapy can be difficult in some cases. The objective of this presentation is to explore the evidence to support the role of the dietitian as a member of the interdisciplinary team, generally and specifically when working with seniors at risk of polypharmacy. Unfortunately, the dietitian is often the only person on the multidisciplinary team focused on successfully integrating medical nutrition therapy with polypharmacy in both the general population and individuals experiencing polypharmacy. Side effects include nausea, vomiting, diarrhea, constipation, and increased or decreased appetite. While other members of the team may want to solve these issues with changing drug regimen or adding more drugs, the dietitian can act as a patient advocate to combat these issues through nutrition. Increasing fiber intake to help with diarrhea or nausea, adding an oral nutrition supplement to boost intake for those with decreased appetite. The dietitian is the patient advocate for energy intake in these situations. Here are some key considerations for medical nutrition therapy and the nutrition care process. Assessment is important to understand the patient's current problems related to their nutrition status. Obtain client history, biochemical data, medical tests and procedures, medication regimen including timing of drugs and meals. When you review assessment, be sure to define current drugs, drug-drug interactions, and drug-nutrient interactions. The Handbook for Drug-Nutrient Interactions, written by Joseph Bulata and Vincent Armenti, is a good reference to use when notating these interactions. Malnutrition and polypharmacy have been linked in the past and will be explained in the literature review. This may be a part of the nutrition diagnosis, but not always. Intervention may include altering timing of meals, avoiding alcohol, or recommending foods to avoid or consume more of to support medication efficacy. Food and nutrient delivery and coordination of nutrition care by nutrition professionals may be 2 interventions most relevant to this process. Always follow up with the patient to make sure pharmacotherapy is not infringing on nutritional well-being. When any new drugs are prescribed, repeat the nutrition care process to ensure successful integration of medical nutrition therapy with pharmacotherapy. The Academy of Nutrition and Dietetics promotes a team approach to care for clients receiving concurrent medical nutrition therapy and pharmacotherapy, and encourages active collaboration among dietetics professionals and other members of the healthcare team. A distrust of expert nutrition knowledge was found among elderly adults in Ecuador. This distrust is associated with a disconnect between expert knowledge and the household. One common complaint from surveyed individuals was that different healthcare providers give conflicting advice. A physician provided a list of good and bad foods, while a dietitian recommended that there is room for everything in moderation. This research from Ecuador calls for universal guidelines that can strengthen the role of the dietitian on the healthcare team if implemented correctly. Pharmacokinetic changes related to aging, including hepatic elimination and renal excretion, can affect ingestion or absorption of nutrients and increase or decrease energy requirements. However, it is difficult to determine the independent role of drugs on nutrition status due to the fact that it is often the disease state that increases likelihood of nutritional complications. In one study on polypharmacy and malnutrition management in older patients with cancer, it was found that side effects of the drugs are the most common issue that affect nutrient intake. This article describes a cycle between the development of malnutrition through intensive therapy or potential drug interactions and the development of adverse drug events due to prospective malnutrition. Nutrition status should be evaluated as part of a standard of care, and nutrition professionals should be the hallmark of the team when educating the patient on drug-related nutrition complications. The discussion above about the distrust in nutrition professionals provides the need for a multidisciplinary approach to the nutrition care process. It may even be important for the dietitian to provide education to other members of the team to better emphasize the importance and relationship between nutrition status and health. It is the RDN or RDN-to-B's responsibility to periodically review literature on the subject. This includes reviewing both drug and food composition databases to understand drug-nutrient interactions and update patient educations. Advances in complementary medicine should also be reviewed, as all three affect one another. In outpatient or other settings where in-person education is not possible, pre-written nutrition education should be provided with the prescription. Use of the Academy's Evidence Analysis Library would be a good location to find the resources to create new patient education resources. Increasing medication effectiveness, maintaining nutrition status, and preventing adverse complications are all jobs of the RDN in the nutrition care of individuals. It is hard to share specific guidelines on how to achieve these three standards due to the highly complex and individualized phenomenon of polypharmacy. Therefore, obtaining information about the drug regimen and schedule of drug and nutrient ingestion is important to know in order to tailor advice to the patient. We are living in an aging society. The research findings synthesized above have, at a minimum, proven that nutrition care and education is important for all aging individuals, especially those living with chronic conditions or regularly taking medications that can impair nutrition status. The RDN is an important member of the interdisciplinary healthcare team. Their most important job with patients experiencing polypharmacy is the successful integration of medical nutrition therapy with pharmacotherapy. More research is needed to better understand improved health outcomes when the dietitian is involved in care. Prospective randomized clinical trials would be the most suitable approach to improve our understanding of a nutrition professional in the nutrition care of the older adult. Here are the references for this presentation.